Hello, my name is Dr. Atul Gupta. I'm paediatric pulmonologist at King's College Hospital, London. I'm joined today by Dr. Venda Pipertanikal, who is the director of the Division of Immunology Research Center at Boston Children's Hospital and professor of pediatrics at Harvard Medical School in Boston, and also by Dr. Siligiani, who is a professor in general practice public health at the University of Crete, and Ms. Monique Cooper, the parent of a child with severe asthma from Miami, Florida. In this section, we will discuss the diagnostic process for severe asthma in children. Dr. Venda Pipertanikal, what is the diagnostic process in your Center for Children with Severe Asthma?
We get referrals from all over, and a lot of times the first thing that we do is really make sure that we have a good understanding of how the patient is doing. Sometimes they actually get referred to us and they don't actually have asthma, they have something else. And so we really take a really detailed history and physical and really review what has been going on with the patient to make sure that they do have that. And then on top of the straightforward history and physical, we also, of course, get lung function testing and to get an idea of what their FEV1 is and their FEV1 over FVC, whether they're reversible or not with their airflow obstruction. Sometimes we also, even if we're not really sure, we might get methacholine reactivity testing. And we most often, always, me being an allergist, of course, want to make sure that we're not missing any allergic triggers. So we do allergy skin testing and get IgE levels and specific IgEs to look for triggers. A large percentage of patients who have asthma in children particularly have allergic components. And those are important to at least get started. Then, of course, we usually also, if we're thinking that they really need to up their medications or think about biologics, we always also get a CBC with differential and eosinophil count. We often get an FeNO as well to see if that's elevated, and then also to look for other markers, blood eosinophils, IgE, that could help guide what we want to treat, where we want to go with it with biologics. Part of the detailed history is to really understand if there's some environmental triggers. We also always, on top of confirming the diagnosis, which usually by the time they're referred to our center, we have the diagnosis correct, but we do monitor adherence because that's also important, and also inhaler technique, because those are some of the biggest hurdles that sometimes patients aren't taking their medications properly, or they're not using them. They don't have a good understanding of how to use them. And also go through other conditions that might be making their asthma worse. Often these patients have other comorbidities. They have allergic rhinitis, they have atopic dermatitis, they have chronic rashes, they have other things that might go along with that as well. And then also get a good history of other specialists that they may have seen. This is really kind of often needs a multidisciplinary approach with different types of specialists to try to manage a disease that can often affect different areas of their lives.
Thank you. And clearly in UK as well, we have a very similar way of using a multidisciplinary team to diagnose children with asthma. How do you diagnose severe asthma in a primary care, and how would you manage?
Obviously, it is very different from country to country, so not all the primary care facilities have spirometry, but they do have peak flow, or they have accessibility to EOS or blood tests in general, so that's good markers. But I will go one step behind, and I think the main challenge is the referrals to secondary care for the diagnosis, and this is a complicated system. because there you need the collaboration between different people, and as you want more people to be involved, then the case always becomes more complicated, but at the end more productive.
How do you, as a parent, your perception was when you were interacting with different multidisciplinary team during the diagnostic process?
During the diagnostic process of my son, started at a very young age. He was pretty much diagnosed at the age of 2, but around 4 is when he started to get tested. Everything started with mostly the allergy testing to see exactly what his triggers were. And we found out that there were a lot of allergies to environment and food and animals and things of nature. So the part of educating the parent was basically this is what was needed for him and what he needed not to be around. We started that and the education of it also with the simple triggers and what were the signs that can lead into an asthma attack, which started with a cough. My son was very severe at the age of 4 due to when he was coughing ongoing, and then it, as a parent, we just think of a cold, as simple as that. But once the doctor started educating us, as sometimes a cough can be more than just a cold.
I think when we educate also the parents and the children, we are not very specific in some indications. Let's say we thought that the people should know that. So for the example, the indoor smoke from cooking or from fuel, from heating the house is something that we rarely say, but this could be a really important cause. So most of the parents, I think, at least from my practice, they focus on aeroallergens, but they forget the food allergy, or they don't know the food allergy, or other factors. So, for example, e-cigarettes. I haven't seen any doctors to train for e-cigarettes as well to mention it as a factor, although we always mention the smoking. So I think this is the way that we should all work together and see what is needed for the patients and for us to improve.
And as a parent, it is good for all parents to give every detail of what their child is around and what they're eating. For an example, my son had a severe asthma attack, ended up in ICU in the one summer, and that was because he was eating popcorn almost every day, and he's allergic to corn.
Dr. Vanda, and from a tertiary perspective, where do you use the biomarkers? You already suggested using blood eosinophils, IgE, and FeNO at the diagnosis. Is there any other steps would you use the biomarkers for?
Yeah, so I think it's really important, as I mentioned, particularly in children, type 2 inflammation or allergic inflammation is super important in the pathophysiology of asthma. And that's why getting those markers can kind of guide you whether those are elevated, and that may help determine, because there are multiple therapies out there, particularly in biologics, that really target that type 2 pathway. And that's a very important endotype in severe asthma. And what happens is when you knock down that type 2 inflammation, you can help not only their asthma, but a lot of other conditions.
Thank you. And from the primary care perspective, where would you use the biomarker testing?
I think a first indication would be with blood eosinophils, because this is the one that we always have in records, let's say. And the challenge is that we don't have access to FeNO, which is widely used, and it could be really helpful. But in some countries there is. So I know, for example, in Netherlands, it's widely spreading all over the primary care practices. but this is not the case for Greece. So access to IgE, for example, depends on where you live and where is the primary care practice. But again, I will move again one step behind this. The challenge is to suspect that the child has type 2 inflammation, and also not only to suspect, but to know that, to persuade also the parents that there are treatments to make your child feel better and be more safe.
And the final question to you, Ms. Molly Cooper. So you said your son had asthma at 2 years of age. So at what stage was the biomarker testing recommended? And how was this explained to you?
It was recommended around the age of 4. He got tested, and they explained how it was explained to me was basically they want to see what can be done to give him a better day-to-day living. Due to his condition, he was missing school, not in school due to asthma, always in the hospital, in ICU. We was trying to get it controlled. Started with allergy shots, and then that didn't work. The testing of different medications that would be on. He finally got, at the age of 10, finalized with one medication that he's able to take every 2 weeks to control his allergies and asthma, along with taking his everyday medication twice in the morning, twice at night. It was explained. The best thing I can say, though, for a doctor to help a parent with a child with severe asthma, if the parent can really get the doctor in their business as far as what the child is doing every day. My son is very active with sports, and that can be a trigger at times, during different seasons of the year, where we're, hey doctor, we're going out of town. If the area have a lot of trees or woods, we let the doctors know exactly what we're doing from a every 2 week basis. This is what we're doing. This is where we're going. That way we get medical advice on how we should proceed with his health, where we're located. So they explained everything very well to me as far as getting him into getting tested from day one up until he was 10 years old.
Thank you again for all my co-faculty members and the audience for watching. You can find out more about the management of pediatric severe asthma in other short videos in this activity.
Hello, my name is Dr. Wanda Pipitanical, and I'm the director of the Division of Immunology Clinical Research Center at Boston Children's Hospital, and I'm a professor of pediatrics at Harvard Medical School in Boston. I'm delighted to be joined today by Dr. Atul Gupta, who is a pediatric pulmonologist at King's College Hospital in the UK, and Ms. Monique Cooper, who is the parent of a child with severe asthma from Miami, Florida. In this section, we will discuss the use of biologics in children with severe type 2 asthma. So I think we'll begin by maybe starting the discussion with Dr. Gupta and talking a little bit about some discussion on assessing disease burden in patients and families, and when do you start thinking about initiating biologics, maybe a bit on some of the available biologics and your approach to selecting the best one for your patients.
Thank you, Dr. Venter. So in our severe asthma clinics, we follow a shared decision-making and is a multidisciplinary team who evaluates the children. And besides the diagnosis, we also look at the impact of severe asthma on the child and the family by looking at the quality of life questionnaires, but also assessing how much of oral steroids children has had in the past. And as we know, oral steroids are wonderful in treating acute asthma attacks, and we have been using it for more than 7 decades. But as few as 1 to 3 courses of oral steroids prescriptions every year increases the risk of developing corticosteroid-related complications, and the short courses of high dose of inhaled corticosteroids can even cause behavioral changes and anxiety and other side effects. And the long-term effect of corticosteroids are on growth impairment, looking at cataract, pubertal disorders, obesity, reduced bone density. So focusing on the disease burden, both in terms of amount of corticosteroids, but how is it affecting day-to-day in the life? So how much school they are missing, are they able to exercise or not? The weight gain they may be having, and that influencing the poor exercise ability for them to do it. Looking at comorbidities like sleep apnea, and then taking into the account of whether the patient is suitable for a biological treatment or not. And once we think the patient is suitable for a biological treatment, we discuss with the family as a shared decision making in terms of what the biomarkers are available, what are the options available for that child and the family, and what are the practical issues involved, that is the frequency of biological agents, how many injections is it? Is it a single injection, or will that be 4 injections for that patient? Is it 2 weekly, 4 nightly? Some of the biologics we are able to give it at home, and some needs to be administered in the hospital, and the side effects profile of it, and then make a decision after the shared decision making, what would be the best biologic for that family.
Yeah, no, that's really great a tool and kind of an overview. And yeah, I think one thing that we have really learned over the last few years is so much about the different biomarkers and disease endotypes when it comes to asthma. And we have really exploded in the area of immune-based therapies and biologics in the last few years. We used to just have one that targeted IgE, which is central to allergic processes, and that's been around for 15, 20 years. But now we have several biologics that target IL-5 directly, which is a cytokine that works on eosinophils. And one of them also works on the receptor. And so that works on the eosinophil disease. And then there's another biologic that works on the IL-4 receptor that really blocks IL-4 and IL-13 as well. And so that's 5 really targeting type 2. And then there's a new one that really blocks or works on TSLP, which is a marker that really works on both type 2 and type 1 inflammation. And so I think, like you mentioned, just really kind of assessing how the disease really burdens the patient and the family, and maybe thinking about whether biologics would be the next step. And like you mentioned, Atul, other comorbidities, because some of these biologics are also approved for even other conditions because they work on type 2 inflammation and there's other disease processes. So Monique, what do you think about this? I mean, this is a lot of maybe big words and mumbo jumbo about biomarkers and morbidities, but you as a patient or a parent of a patient, what is your understanding of biologics, and what are some of the questions you have if a doctor starts to discuss with you about this as a next step?
As a parent, I just want to, some of the questions that I would have would be anything that, can affect my son's day-to-day living. Is it something as far as side effects. What are the side effects? Are those side effects going to affect him? Should I take this knowing he may have this certain side effect? Like Dr. Gupta said earlier about steroids. That is something that my son was consistently on from the time of him being diagnosed with asthma. The actual steroid that he was using was the one, like I'm gonna say the end game of him becoming better in his breathing, and the biologics of what you all say. Basically, I ask a lot of questions as a parent. What is this? What is it going to do? How is it going to affect my son? When do we use it? What are we going to do with it? All of the above, because when they're young, from a certain age, like toddlers, the parents are the ones that administer the things that they have, give them anything that they need, because they're not old enough or responsible enough to, take on and be able to even tell you what is wrong with them. Because as parents, we still have to watch how they breathe in.
These are all really great points. And it's always great to hear parents' perspective on a lot of these questions. Atul, how would you answer maybe some of her questions and concerns? We could probably talk all day, but I'm hearing stuff about like how is this going to help, right, your son? Maybe some of the logistics. Do I get it in the hospital? Do I do it at home? How do I do it? And I'm hearing also a little bit about safety and how will they, affect quality of life. So Atul, what do you think would be your approach in helping answer Monique's questions and concerns?
So in terms of selection of the biologics, we have a shared decision making where we take into account how old they are, what the phenotype, endotype is, what the weight of the child is, how it can be given, what's the route of administration, how does the drug work, so what is the mechanism of action, the safety profile, how long the biologic has been around for, and what sort of studies has been done to convince us as a clinician and for us to convince the child and the family what is the safety profile, the frequency, how frequent it is, what is the biomarkers, exhaled nitric oxide, IgE, atopic status, but also, as you said, Venta, looking at the comorbidities, airway obstruction, and looking at when did the symptoms started, how frequently the attacks are happening, and also in some part of the world is the cost of the medication involved, and looking at the IgE and the IgE and the degree of eosinophilia to help to make that decision in giving the biologic, and also not forgetting the research route, because currently there are a lot of newer biologic. If somebody doesn't fit into this profile, then there could be potential route to enter via a research route.
Yeah, no, those are all great points. Now, does this intrigue you a bit, Monique? Like, say, your child has been getting a lot of steroids and has been in the hospital with really bad asthma. And would you consider going down the path that they are injections, biologics? I don't know how your son would feel about that, but we have learned so much. They act directly on many of the things that affect a lot of the quality of life of your child. And some of them are approved for other indications. You're mentioning some of the other allergic conditions that you could kind of get with the same treatment. What do you think about that, Monique?
I think it's awesome because he actually does get an injection every 2 weeks. The one where he will sit and wait for the doctor. Yes, he gets an injection, and it took us quite a while, but from the, like I said, starting really at 4 years old when he started getting tested or whatnot. The age of 10 is when he started those injections, and he's now currently 15, and he continues it, and it works. He has not had a severe ICU incident since the age of 10.
So that's just a wonderful story to hear about a treatment that works. And I think that it depends again on the patient and the family, but you are at that point, right, in your child's life and disease that, like, I want to take the next step. And it's every 2 weeks. It's a commitment, but it seems like it has made an impact on your child's life and your child is still using. So that's really powerful. I really appreciate you sharing that. You can find more about the management of pediatric severe asthma in some of the other short videos in this activity. Thanks. Hello, my name is Dr. Wanda Pipitanical, and I am the director of the Division of Immunology Research Center at Boston Children's Hospital and professor of pediatrics at Harvard Medical School in Boston, Massachusetts, in the United States. I'm delighted to be joined today by Dr. Atul Gupta, who is a pediatric pulmonologist at King's College Hospital in London in the UK, and Dr. Iona Siligiani, who is the associate professor in general practice and public health at the University of Crete in Greece, and Ms. Viv Marsh, pediatric asthma nurse specialist and asthma clinical lead in the Black Country, West Midlands, UK. In this section, we are going to be discussing the role of a multidisciplinary team in the management of patients with pediatric severe type 2 asthma. So I'd like to begin the discussion by thinking about how we monitor our patients. And I'll start with asking Dr. Iona, from a primary care perspective, how do you monitor how your patients are doing and how they're responding to treatment?
Yes, I think, thank you, Dr. Vanda. I think the most important part is that the child first feels good, let's say in simple words, and avoids exacerbation and risk for hospitalizations, but also the parents feel that their child develops and handles well with life. I think the best way, to my view, personal view, is to use some structured instruments to assess the control of the disease and also to assess the quality of life. So the CACT or the ACQ could be good suggestions to see if the response is working because and the most important for me is that if you use a structured way with a questionnaire, then this could be repeated and you can see the improvement or the deterioration of the status of the child, apart, of course, of assessing always symptoms, history, and etc. And I would like to add at this point that these questionnaires, to my view, again, depends on who is using them, of course, but also the experience that you have. So, for example, I like the carrot kits because I can also assess, we have already mentioned, the important role of comorbidities. I can also assess in one questionnaire the allergic rhinitis, for example, and this is really important for me. And the fact that the child can also address the questionnaire because there are infographics in, so I can have a good view of the child as well.
What about from a nursing management standpoint, Ms. Viv? Do you have any thoughts on when you see your patients?
Yeah, certainly. I think, to add to what Iona has been saying about quality of life questionnaires and control assessment questionnaires, which are incredibly useful and often really useful as a starting point for a really good conversation and discussion with children and families, I have to say. But to add to that, some of the things that I might consider as a specialist nurse, particularly working in the community with children and young people with difficult and severe asthma, I might be thinking about things like participation, the wider sort of lifestyle issues. So participation in activities, things like sleep, things like family dynamics, and also things like school attendance. And I do a lot of work in schools, a lot of work with teachers and also with children in schools. So, how well are they settling in school? How well are they learning? Are they able to concentrate, or are they so tired from having nighttime asthma symptoms that actually it's really affecting their behavior or their concentration levels in school? So all of those sorts of things I would consider to bring together the whole picture. But as a specialist nurse, I get a lot of opportunities for home visiting, and that gives us really great insight into family dynamics and perhaps what's going on in the home as well.
That's fantastic. I just can imagine how beneficial that is to your patients to really go out into their community and to really kind of understand. And it sounds like a coordinated kind of multidisciplinary approach, working with the school, working with home, working with the families can really make a difference. And your role is so, so vital. So we really appreciate that. What about you, Dr. O'Toole, from a specialist standpoint? What do you think about when you're thinking about coordinating the care of your patients and monitoring and making sure that the treatment plan is working?
So from a specialist perspective, is a severe asthma needs to be managed by a multidisciplinary team. And we heard from Viv about the role of the specialist nurses, but also the role of physiotherapists, the pharmacists, the dietetics, and the psychologist. It's both the impact of severe asthma on the patients and the family, which needs to be monitored, but also to evaluate the side effects from any of the medications which the child would have had in the past. So looking at the comorbidities as well. So in addition to, I think, asthma control tests, we use that very frequently and it's very helpful. School attendances are a great way of looking at it, but also looking at to help the patient to take medications, looking at the treatment management plan. Is that simple enough for them to do, using them smart inhalers so that we have an idea of how much treatment they are doing it, but also as a reminder for them to take it using exhaled nitric oxide spirometry. With the COVID, we almost start using a lot more home spirometry on the patients who are able to maintain to the lung function test routinely at home.
I think as an allergist, I mimic a lot of these where I really try to coordinate the expertise of the nurse, the family, understanding how things are at school and at home, and working with the specialists and the pulmonologists as well, and to a really coordinated multidisciplinary approach. And I also like to focus as an allergist, managing those modifiable risk factors. If we know that there have specific triggers, and a lot of the work I've done for the last decade has actually been in school specific triggers and trying to make an impact on the school environment.
From country to country, things are completely different. And we all know, and we think the multidisciplinary collaboration is a key factor, of course, to be able to manage well severe asthma, but also any other chronic condition. But the problem is, I don't want the audience, to have the feeling that this is available everywhere. So this depends a lot on socioeconomical status of the country, of course, and many other factors, the geographical variation. So the teaching of the schools and the teachers, for example, is really crucial because they can have good monitor of the children, but also avoid allergens and many factors, and they can monitor well. But if there is no multidisciplinary team or there is no access, then the primary care physician should be also there and try to teach the children and the the teachers as well. And of course, home visits are really crucial because they give you a good impression of the family dynamics, as you said, Dr. Mars, but also the conditions, because there is a lot of poverty in many places, and poverty is a risk factor also for exacerbations of asthma.
Also, not forgetting about the poor medication adherence to inhaled corticosteroids is most primary cause what we see in difficult to control asthma symptoms, and the primary care professionals have an important role to play, and also, even though we have taught the parents on multiple occasions and how to use the inhalers, whenever we revisit it, is always there's a room for improvement. And the research studies have shown between only 8 to 25% of children are able to use inhalers as they should be. So looking at the focusing on the basics is also very important before we start looking at the expensive biological treatment. And then majority of the patients, I think, the basics is what is required, focusing on inhaled corticosteroids, asthma education, and the inhaler technique.
The inhaler technique is really crucial, and I think that's what I said also before. It's really important, and we don't invest a lot of time in that. We recently finished a study, which was a European study with many countries being involved, with even video recordings of the patients, and the errors were enormously high. So I really support your point, Dr. Gupta.
I think this brings us to the close of this particular discussion, and I'd like to thank the faculty and the audience for watching. And if you want to find more information about the management of severe pediatric asthma, you can check out some of the other short videos in this activity. Thanks.
So, hello, my name is Dr. Ioana Tsiligianni, and I am an associate professor in general practice and public health at the University of Crete, Greece. And today I'm joined by Dr. Vanda Pipatanikol, the director of the Division of Immunology Research Center at Boston's Children's Hospital, and professor of pediatrics at Harvard Medical School in Boston, Massachusetts, USA. And also Ms. Viv Marsh, pediatric asthma nurse specialist and asthma clinical lead in the Black Country, West Midlands, UK, and Ms. Monique Cooper, the parent of a child with severe asthma from Miami, Florida, USA. In this section, we will be discussing how we can best support families to optimize patients' outcomes. So the first question to you, Vanda, is how do you think we could overcome barriers to adherence, and which do you think are the factors that influence adherence to biologic therapy, and how do you think we could address them? What's your experience in that?
Yeah, those are great questions. Adherence is such a major factor when it comes to difficult to control asthma. And there are several factors involved in that. First of all, the complexity with the inhaled medications really can be daunting to the patients. Which one is my rescue medication? Am I using this properly? Which one do I use when I'm having an asthma attack? All the different colors. And so that can make it very difficult. Then there are pills. Then there are different kind of frequencies that you use them. That can all factor into adherence. And then patients often have the perception that I'm going to get bad side effects from steroids. I want to stay for them, so I don't want to take them nearly as much. So that's one of the factors. And then as their asthma gets worse and we start thinking about biologic therapy, because that's currently more approved for the more severe asthma patients, then there's the fear of safety and injections, and do I come into the clinic and do I have to do them at home? So all of these are important factors that I think we as providers who care for these patients have to really have a strong discussion, a shared decision making between the patients and the parents and the caregivers in what the therapy is, how does it work, what is your asthma action plan, and how does that intersect with your potentially every 2 to 4 week or 8 week shots, depending on what you're doing. And so education and really having a good dialogue with all of the caregivers in the patient's care and the child's care, including home, school, and community, I think are some of the key things in trying to overcome barriers to adherence, which is very difficult, as you mentioned in the past.
Thank you. I think from the primary care point of view, before I move to Ms. Mars, is one other factor that I found very crucial is the accessibility of care. So, for example, biologics are not available in my country in the primary care field, and this is really challenging sometimes to be able to take the patients to travel to other facilities in order to do that. And also health literacy is really important, because sometimes the parents don't have the health literacy required to realize the risk, at least for their children. So I think we need a lot of elaboration in that field. So Ms. Mars, what's your view on that, in the same question about the factors that influence adherence, and how do you think you could improve that?
Well, I think really just to add and to build on what Wanda and yourself, Iona, have been saying is accessibility is a real problem. So in the UK, children with severe asthma on biologics are managed primarily in the tertiary care centre. We don't have many of those in the UK. And one of the things that we do have that we're quite strong on is shared care arrangements with between our tertiary care centres and our secondary care centres. So very often families can alternate their visits to the hospital between the tertiary care centre, which for many families might be 50 or 60 miles away, with their more local hospital. And then, of course, obviously, if they have specialist nurses, they get very involved in coordinating the care. I work in an area of the UK which has very high rates of poverty and ethnicity. We are severely affected by health inequalities, and the cost of travelling to appointments at tertiary care centres is a huge barrier.
And Ms. Cooper-Monick, which was the main factor that influenced the adherence to the biologic therapy for your family? And what could be done differently, let's say?
Well, here where I'm located, the main factor probably as far as with my son getting the biologic therapy was getting there with working as a parent. The doctor's office that he goes to opened up their hours for parents who work certain times where they're located. They're there a little late. So for a parent like me that works a 9 to 4 job, and the office at the clinic may close at normal hours is 5. They extended to 6, where I would be me or any other patient that can come in, that is coming in like me every 2 weeks, can be the last patient if need be. That was mostly my concern. Of course, getting there, and this is a every 2 week thing, so I have to make it a part of my everyday schedule.
Yeah. What's your experience on a multidisciplinary team? So, for example, who monitors the inhalers? Did you have instructions on modifiable risk factors? Was that useful? what would you need differently, or what worked well?
Well, I can go by the experience from beginning to end. My son takes he pumps in the mornings. That's one thing that he does. He does that in the morning. He has that at night. Because he's an active child in sports, he also has his emergency inhaler that he would take 30 minutes before he goes out in the field of anything that keeps him active. That way he's controlled. After that, he might have to take it again before his nightly dosage. He also have pills that a pill that he takes every night that helps with his allergies, and then he has his nasal spray as well, which all is a combination for his severe asthma because those help with his triggers. And on top of all of that, every 2 weeks he gets his injections. So what can be done? I think honestly, just having that parent-patient doctor relationship helps a lot with everything that we have going for his severe asthma, because they're able to let me know exactly what is needed for him. I'm able to be frequently and free in my speaking with them and letting them know, just being transparent as a parent. This is what Jaden has going on. This is what he's doing. This is what we have going on as far as what's in the home, everything from being around smoke, having animals in the area. So it's a lot with caring for the child and communicating with the doctors. But honestly, I don't think I have anything that I can say that can really change, because it's the parent. Here, the doctors actually listen and hear us out. It's up to the parent to actually be transparent, to let the doctors know, don't hold nothing out, because the doctor will not know. And also research. The parent has to research. You can't just say something and keep it with no details, and the doctor will not understand. I'm not going to say understand. They will have to go through so much just to figure out how to help your child, because every child is different when it comes down to even different type of inhalers.
Yeah, I think it's about remembering that every child is an individual. It's about that real thorough, complete, holistic, multidisciplinary assessment of every child and family, and really trying to get to know children and the families, trying to understand them so that we as healthcare professionals can understand what it is they know about their asthma and what it is that they want for the treatment of their child or for the child themselves. And one of the things that's advancing quite a lot now is directly observed therapy. And in the UK, one of the areas that we help with that is children, if we're concerned about their adherence, might have their therapy observed in schools, for example. Our schools are very engaged in that process, and we have good sort of shared care and care planning going on between schools and healthcare professionals to support families with that. And then also, greater advances in technology are really helping us as well. And, Monique's spoken about how difficult it can be to get to appointments. She's a busy working mom, but, we're using much more remote options now, aren't we, for certainly monitoring and assessing patients, but also we can do directly observed therapy via remote video mechanisms as well. So I think, for the future, those sorts of things are going to be used a lot more.
Yeah. So thank you very much. I think we had a nice discussion. I want to thank my faculty for joining. And I think we raised a good discussion about the family and how we can support that. And also the experience of you, Monique, is unique to be presented to us, and we can all together we can work to improve this collaboration and this communication between family and the MDT group. Thank you.